Assalamualaikum warahmatullahi wabarakatuh. My name is Nur Ali Nazira. So right now I will present about pacemain for the PA chest projection. So as you can see, based on this picture, the distance between left clavicular end and the right clavicular end to the sternum is not equal distance. So that means there are a rotation to the left. To improve this, rotate the patient until MSP perpendicular to the IR. Okay, besides that, patient shoulder are moved forward perfectly. It's evident by the edges of the scapula located outside the lung field. Okay, so next, there is also no tilting evidenced by 2.5 cm of the lung apice are demonstrated above the clavicle. Patient shoulder are also elevated, evident by the clavicle are not in the same horizontal plane for the both sides. Patient also not in full rotation because of tense rib are not projected above the diaphragm. Also, heart shadow is not enlarged, evident by cardiothoracic ratio is well within normal limits of 50%. Next, for the alignment. First one, alignment between atrial tube and image receptor or IR is correct, evident by distance between collimation border of superior, inferior, and lateral is equal distance. For the alignment between atrial tube and the part is incorrect, evident by center of collimations not aligned at the center of the part. For the last one, alignment between image receptor and the part is also incorrect. It is because center of image receptor are not aligned with the center of the part. So, where is the centering point? The centering point for the PA chest is at the level of the T7. To improve this, adjust the centering point of collimations at the level of T7 and also adjust image receptor at the same level as the centering point of collimation. Next, for C or collimation. For the superior border, it includes lung apice. For the inferior border, it includes costophrenik angle. For the lateral border, it includes lateral skin margin. As you can see at the lower part for this image, there is presence of radiographic apparatus seen in the radiograph. Next, for the exposure. KVP use is inadequate for penetrations and radiographic contrast. It's evident by bony cortical outline for the thin structure, which is vascular marking, can be visualized. But the bony cortical outline for the thick structure, which is thoracic vertebra, cannot be visualized. Next, MAS use is inadequate for detail and density. It's evidenced by the bony trabecular patterns for the thin structure, which is air-filled trachea, can be seen or can be visualized. But the bony trabecular pattern for thick structure, which is vertebra body, cannot be seen clearly. To be concluded for the exposure, KVP must be increased by 15% and MAS also need to be increased by double. Usually, optimum exposure factor for PA chest is 90 kVp and 5 MAS. For the M, marker. There is no presence of radiographic markers shown in the radiograph. The marker should be placed above the level of the shoulder. For A, the film size is 35 times 43 cm, which is suitable for demonstrating structure of interest. The last one, for name. Patient names and ID, date of examinations and place of examinations are present on the radiograph. The placement also suitable, which is at the below for the radiographic image. To conclude, the radiographic image nearly perfect. That's all. Thank you.